Today, we'll talk about your topic for your lecture, educational session next year. It's about omitting surgery for exceptional responders after neoadjuvant chemotherapy. The topic's been getting increase of attention lately because thanks to many publications, especially many of your publications that you're definitely a pioneer in this area of research. My first question is, how did you get the idea at the first place, and how did you become the leader?
Thank you. I think for two main reasons. The first is I distinctly remember when I was a surgical fellow at MD Anderson, a patient who had a large breast cancer, probably 6-7 centimeters. She underwent, of course, neoadjuvant chemotherapy. And at that time in 1998, we were beginning to know that if you had a complete pathologic response, then your survival and chances of it coming back was survival high, chance coming back very low. So the patient obviously had a mastectomy. It really was, she had a small breast and it was occupying, at least close to half of her breast. And I remember going in with my mentor, Dr. Singletary, and telling the patients, good news, there's no cancer left in the breast, there's nothing in the lymph nodes. And she said, well, then why did you take my breast off? And she was very upset about it. So essentially that was kind of haunting us and others around the world. Certainly at MD Anderson, we've been trying to do less and less surgery. We've done that, of course, not only with the breast, but in the lymph nodes particularly. And the second real reason which got me into this, re-exploring it, the concept of it, which is not new, it's been tried for 30 years in other trials with not great success, probably because they didn't use good breast imaging. But, we designed, tested, and implemented this targeted axillary lymph node dissection, or TAD as we call it.
Right.
So, we knew that in triple negative and HER2 positive cases that 60 to 85% of those lymph node mets were going to go away. Mm-hmm. And we were putting a clip in the lymph node, and that was the hypothesis that we could test one of those, and then it would give us a reflection of the other nodes. And essentially, it is very accurate in the 98% range. And I said, well, why aren't we doing this again in the breast? We have a clip in the breast where the tumor is. Why can't we retry this again using stereotactic biopsy?
Mm-hmm. So your experience with the patient, that's the experience we have every day in the clinic with our patients as well. We do get the same questions from the patients. Why did you have to do the surgery? Or before, during the planning process, we tell them from the imaging, we think it might have gotten all the way. And they say, oh, then do I have to get the surgery? And I just tell them, unfortunately, for now, you will need surgery. But obviously someday in the future, I will be able to tell her with confidence that after a simple biopsy, I think you might be able to spare the surgery, and she'll be really happy with that, right? And also, I didn't know that the initiation of this idea was from TAD, which is obviously a concept that's very well implemented in the clinic, right? I will just go on to one of the questions questions about the trial that just started in Europe, eliminating sentinel lymph node biopsy after neoadjuvant chemotherapy. Your Hale, I think, introduced that to us at San Antonio Conference Symposium last week. What are your thoughts about that, eliminating surgery for the axilla after neoadjuvant chemotherapy?
We took a look at this at MD Anderson in triple negative and HER2 positive cases, tumors less than 5 centimeters.
Right.
When we were designing the concept of no breast surgery, we had concern that we're going to be leaving disease in the nodes. So one of our fellows, Dr. Audrey Tadros, now at Memorial Sloan Kettering, took a look at our experience of those cases that had a complete pathologic response in the breast. And we said if the patient came in with an ultrasound of the nodes that were clear and had a complete pathologic response in their breast primer, we asked the question, and I think there are about 500 or so cases. We asked the question, how often are we going to find lymph node spread in those lymph nodes when we do the surgery? And essentially 0. You know, we always worry when it's 100% negative predictive value.
Right.
So working with colleagues at Mayo Clinic, Dr. Barron looked at the National Cancer Database in the USA, and we didn't select these patients based on clear normal ultrasounds of the nodes. We just used a clinically negative axilla. And we asked the question, how often when there's no invasive or DCIS in the breast after neoadjuvant systemic therapy, in about 13,000 patients, are we going to find how often it's going to be negative? And essentially it's like 98.5%. So less than 2% of the time we're going to find lymph node spread in those cases, which is less than our false negative rate just for doing a sentinel node. So I think taking that data, I think other clinical trials, I think what you're referring to is the EU Breast 001 trial, where they're going to be looking at that. And I love in their study, they select the patients for this single arm study by looking at those cases who have a complete radiologic response in the breast, and then they become eligible to be in the trial if they do a lumpectomy and there's no cancer. I think that's a great way to select the patients because in our experience, it's like 80 or 90% of those cases are going to not have any lymph node metastases. So I think that's good.
Referring to your the studies done by Dr. Tadros and Barron, when we look at the subgroup of patients where patients had a clinical and node stage 2, the numbers go up, right, to about 15%.
Yeah. So in our clinical trial, we have a trial open now, by the way, to test no surgery in these cases. And that's, I think, real important. None of this can be done as a standard in patients. This concept of no surgery for invasive breast cancer after neoadjuvant systemic therapy is just an idea. Just like 70 years ago, when we were testing in single center studies and learning about breast conserving surgery, we're still very early now. As you know, you've done a lot of studies at home in Korea. So in those cases where it's node positive first, if there's a complete pathologic response among those particular cases, less than 5 centimeters and triple negative HER2 positive, it's about 10%. So even with node positive cases that start out with up to three abnormal nodes with biopsy proven, we're offering patients the option of a small incision under their arm to do targeted axillary dissection. And in that scenario, in our hands, based on our trial evidence, it's about a 90% chance there won't be anything in the nodes. Right. And of course, these patients are receiving radiotherapy.
I agree. I think radiotherapy is a very important factor that they will be receiving radiotherapy. Okay, you do have a study going on, actually omitting surgery for, I think the target is 50 patients, right? So we're expecting the results in 2022, I think. Is that right?
Yes, we're hopeful. The first reports. These again, this no surgery for invasive breast cancer is a study, is a clinical trial. It is not standard in the US and should not be standard anywhere else. We're testing it. Patients are eligible if they have, and that's another concept about this. You know, we have to be super selective, just like you did in your recently published paper in breast cancer treatment. Recently, actually, I just saw it come past my desk. You have to be super selective in the patient. So these patients had to start with tumors less than 5 centimeters, have to be HER2 new positive or triple negative. But just like you found in your study, we found that we had to go have an imaging residual after neoadjuvant less than 2 centimeters. Why? Because we can sample that well. We designed it. We need, based on our initial study, if we didn't take enough cores, it was not accurate to tell us if there was residual disease or not. So we do 12 vacuum-assisted 9-gauge core biopsies, and people, they think, oh, am I going to get stuck, 12 times or whatever? No, it's one stick. It's done by expertise of our radiologists who are essential in this team. And again, this is another critical part of the field. They can do this by MRI guidance. They can do it by ultrasound, MRI. We have to use the best modality which shows suspicious abnormalities. They may be microcalcifications, but whatever it is, or enhancement, it has to be less than 2 centimeters. So there's our first selection there. Again, our pathologists are key in this and how they're evaluating these specimens. It's complex. If there's nothing on those cores, they don't quite believe it, because we knew they had cancer. They can't just look at one section. If there's none in the first section, they will do 9 additional sections of each of the cores to ensure that there's no disease. We do that, we lower the false negative rate. If there's nothing, these patients go on to receive standard radiotherapy, skipping the surgery altogether, unless they had positive nodes at the beginning, and then we would do a targeted dissection. So I can tell you, as the status, I'm excited to say we only have 6 more patients to go on study. In October, our first patient reached her 3-year anniversary after radiotherapy. I know it's very early, and please don't take this as results, but we're delighted. We're following them every 6 months with imaging, by the way. So we're delighted to say she has, she's fine. She has no recurrence, and that's our main endpoint is local regional recurrence of breast cancer.
And most importantly, the patient is happy, right?
Yeah, so that brings up,
Right.
people say, well, in the US particularly, I don't know what it's like in Korea. They say, I have so many patients who want bilateral nipple-sparing mastectomy for a very small breast cancer. But I think the key here is that, we have hundreds of thousands of women with breast cancer in the US. Just like the breast cancer is heterogeneous, so are our patients. Some patients, if we were able to prove that the survival and local recurrence rates were the same without doing the surgery, some patients would really like that. Right. Of course, it's way too early to figure that out. So I don't think it's a one size fits all for patients with breast cancer. Mm-hmm. And so I think a lot of people are excited if we tell them at the beginning that we have a clinical trial and we talk about it, and we're going to say we're going to look at your response, and it's not standard. Some get very excited about potential. Wow, if I take the chemotherapy, my survival is going to increase, and maybe I'll get another benefit. I can have a biopsy, no surgery. So you're correct. We have very sophisticated questionnaires for the patients who are on this study about their body image, sexuality. They have this thing called decisional regret, where we measure, did I make the right decision? Preliminarily, on the first patients that we looked at, it was in the 90% plus that they would do this again, and they were glad they didn't have the surgery. Again, very early data. We will be reporting that when all the patients are accrued at the 3rd-year mark and the 5-year mark. For the patients are going to be really, really important, especially some critics, including Dr. Morrow, who addressed the issue that only a few patients will benefit
this kind of procedure. But those patients are important, and we do have strict inclusion criteria, as you mentioned, the 2 centimeter lesion according to any imaging, and the number of cores. Obviously, you're getting more than 12, right, for your
12 or
trial?
more. I think so far in our first, in the patients that we looked at who've had biopsy, it was actually around 13. You know, so
Okay.
They had to have 12, but a few had more.
Mm-hmm. And obviously, the needle gauge comes into play because of the volume of the biopsy specimen. And also the recent paper by Dr. Hale about machine learning, looking at all those factors that we cannot assess by ourselves, but we have our algorithm do it for us. All those things come into play. And also, I believe the Swiss group, they started a prospective trial early this year called the Vision 1. They mainly use the MRI findings to include patients in the trial. And so in Korea, Seoul National University Hospital, we're preparing a trial, but one thing that we were not able to decide is whether to do a feasibility trial again, or just go on with the omission of surgery trial. And last year, after San Antonio Breast Cancer Symposium, because all the trials were negative, except for our pooled analysis being highly selective, we kind of decided to go on with another large-scale feasibility trial like the Vision 1 in the Swiss group. But after looking at those selective criterias and also your successful trial going on right now, we have some opinions saying, why not? Why not just go on with the mission of surgery trial? And maybe for those good responders, even though we may miss some of the residual tumor, they might not affect the local recurrence rates or the disease-free survival rates. And those questions cannot be addressed without a large-scale trial omitting surgery altogether. So what are your thoughts on the current situation for design of trials?
So there's several things that I thought about. I would just like to remind everybody in this field that the standard after neoadjuvant systemic therapy is to do breast conserving therapy if the patient would like that. But we only remove what is abnormal on imaging, whether it's mammo or ultrasound or MRI. We don't remove everything. So for us to think that the false negative rate of standard breast conserving therapy is 0, we are fooling ourselves. And I would guess that the false negative rate of a standard surgery, certainly for lymph nodes, is 5%. For the breast and lymph nodes, we may be in the 10% range. So if you're able to find a group of patients where you consistently have a false negative rate in the 5% range, I think those cases, I think it is safe to put those patients on studies to test the concept of eliminating surgery. I was impressed with your study. Yes, your MRI size had to get very small, less than 5 millimeters. You had specific signal ratios. You needed more than 5 core biopsies, and that's key. You got to remove the clip. You got to, have sufficient number of vacuum-assisted cores, and the negative predictive value was 100%. I think everybody knows that we can select patients where they would be at least risk to do harm. And I think whatever group you're in, you have to work really selectively to select the patients where the trials can be safe. Yes, can it work in the multi-center? Well, think about it. Just for breast conserving therapy, how many studies over the last 70 years were single center? You have to develop expertise. You have to try different things. Breast conserving surgery, was started. In fact, all the 6 randomized trials which showed the efficacy of it, we didn't even have standard mammography or an ultrasound. The surgeons just took out what they thought. So I know we can get better. I think the subject is worthy to be tested, most importantly, because I think we're going to be getting a lot better systemic therapies. And at 50% pathologic complete response rate, I think we owe it to the patients to try.
Yeah, I totally agree with you about the residual tumor after we do breast conserving surgery. I think maybe about 10%. We will have residual tumor remaining, but
and not know about it.
Not know about it, and
right.
And because not knowing means that there weren't any recurrences, right? So yeah, I totally agree with you about that. And at this time, I will have to state that I am a researcher trying to develop evidence for this. So we're kind of on the pro side a little bit more. That's a caveat that we have to address. But yeah, that's our role as researchers to develop sufficient evidence, and also sufficient, although it may not affect or benefit a large population of patients, but we do have to offer the patients a choice to receive a treatment was best for individual patients, right? So yes, and I mentioned in the agenda, I had a pleasure of meeting Dr. Giuliano in 2018. He was at our surgical oncology, Society of Surgical Oncology conference in Korea. And I asked him the question about this idea, and he mentioned that this idea was discussed more than 10 years ago at the American Society of Breast Surgeons. And they stopped the discussions because the women doctors in the society, all 100% said that they would rather receive a simple lumpectomy than go under a vacuum assisted biopsy procedure. And there are 2 questions related to this. What are your thoughts about the complications, morbidity of vacuum assisted biopsy, and the simplicity of a lumpectomy that we do these days, especially for patients who have a radiologic CR? And also, what is the consensus or the atmosphere or the opinions of the society currently, both for women doctors and also the breast surgeons in general?
Yeah. So I first have to say that as doctors, we are a little biased.
Yeah,
I can't speak for women because I'm a man.
Okay.
But I do remember I was part of the American College of Surgeons Oncology Group,
Mm-hmm.
and it was more than 10 years ago, and Dr. Giuliano, of course, was leading that.
Mm-hmm.
And what we were talking about at those times was not mixing there was actually a device that you could use percutaneously for very small, I think 1 centimeter T1 tumors, just take it out.
Mm-hmm.
I think we hadn't merged this concept of neoadjuvant with that. But
Okay.
now that, and it may have even been 15 years ago, I don't remember how long, but now we really know that 50, 60% of the cases, there's not going to be any
Mm-hmm.
invasive or DCIS left.
Right.
So I think the thinking around that might be different. What are you asking, like for the American Society of Breast Surgeons and
Right.
Society of Surgical Oncology, what are you thinking? I think there's apprehension. I think there's concern. We've been hearing a lot about, we now have these great therapies for what's called post-adjuvant therapy when we have residual disease. Of course, we've known about capecitabine or Xeloda for triple negative, as well now as TDM1. And I think that is really important. But then I work with my colleagues and statisticians about really how many patients might we miss giving them appropriate therapy. We don't want to miss anybody.
Right.
But let's think about the surgery not being false negative rates in 5%, 10% range. I think it's similar. If we took 1,000 patients, and these are rough numbers, 1,000 patients with HER2 positive disease, triple negative, less than 5 centimeters to begin with. And by the way, we have about 35% of those cases, and all of them mostly are getting screened, and that's how we're detecting them in the United States at this point. So let's take 1,000 patients. In our trials, we're about 60% pathologic complete response. So who could we benefit? Maybe 400 of those patients, maybe with residual disease. But then we look at the false negative rate, at least in our studies, at 5%, or let's say confidence intervals up to 10%, then we have 40 cases, right? 40 cases out of 1,000. But guess what? If they have RCB1 disease, and by the way, every one of the false negatives were very small residual invasive breast cancer. If they have an RCB1 or just a little bit of disease that we missed, their 10-year disease-free survival is around 75 to 85%, depending if it's triple negative or HER2 positive. So there you go, with 20 patients and then maybe a quarter. So maybe we might miss 5 patients out of 1,000. And that is assuming that those drugs were 100% effective.
Right.
So I'm all for improving survival, but I think we have to look at everything in perspective and not just assume, oh, we're going to potentially hurt patients. Some patients, if it proved effective, if it was going to be, a few patients out of 1,000, might they not want to have surgery? Some patients probably wouldn't. Again, we're not there yet because we haven't even proved that it's safe.
Mm-hmm. Right. That's why I think our discussion today is really important to address this issue to the public in general, for them to understand what's out there, what kind of evidence is out there, what we're doing as researchers, clinical researchers, to develop evidence to safely offer these new treatments to our patients, and give them the chance to spare surgery, de-escalate treatment altogether, and sometimes escalate treatments for patients who really need those. And hopefully our GBCC TV and our conference as a whole can really affect our patients, and give them the proper information about the evidence and the proper treatment options that they could choose when they go through the journey of breast cancer treatment. And I would like to thank you again for joining us today in this. It's actually a new experimental content that we're developing, but thank you for participating in our development of our videos.
Yeah, thank you. It's a real honor. I heard that this is the 10th anniversary of GBCC, and I'm excited to be part of it. I'm sorry we couldn't do it in person in this kind of crazy year, but we all have hope perhaps to do it in person in the spring this coming year.
Right. And
congratulations on a great program, and thank you so much for allowing me to be part of this.
Thank you very much.
Bye.
Thank you. Bye-bye. Bye.